Think about what happens when someone breaks their arm.
Right, they go straight to the hospital.
Exactly. They get an X-ray, and there's this jagged white line on a glowing screen. A doctor points at it and says, there's your structural problem. Let's go fix it.
It's very precise.
Yeah, it's engineering. But if we shift the focus to pelvic floor trauma from childbirth, which, by the way, affects over 91% of first-time mothers, that precision just vanishes.
It completely disappears.
Suddenly, this massive structural injury is treated like a mystery, or worse, just a normal part of having a baby that you simply have to put up with.
Which is wild.
So, welcome to this deep dive. Today, we are taking on a mission to answer a very specific, often unspoken question for you. Can an untreated childbirth injury, specifically something called a perineal defect, actually cause an ongoing feeling of looseness?
And we have a massive stack of sources to help us figure this out. I mean, we're looking at joint terminology reports from the International Continence Society and the International Urogynecological Association, plus clinical briefings on vaginal laxity and hospital guidelines on pelvic floor repair. And honestly, the data in these sources points to this staggering disconnect between what patients physically experience and how their symptoms are explained to them.
Yeah, totally. Before we look at whether a physical tear causes looseness, we need to figure out what looseness even means medically. Because reading through these clinical briefings, vaginal laxity isn't treated as like a single uniform diagnosis.
No, not at all. Medically, vaginal laxity is a subjective sensation reported by the patient.
Yeah.
And it can actually originate from three completely distinct layers of the pelvic floor.
Okay, let's unpack this because I think the most effective way to visualize this complex anatomy is to think of the pelvic floor like a house.
That's a great analogy.
Right. Specifically focusing on a door and its frame. You have three components: function, surface comfort, and structure.
Yes.
So function is the hinges on the door. Do they swing smoothly or are they rusted? Surface comfort is the weather stripping around the edges of the door. And structure is the actual wooden door frame itself.
Exactly. So if a patient comes in reporting that things feel loose, the medical provider first has to determine if it's a hinge problem, a weather stripping problem, or a broken door frame.
Let's break this down. What exactly is the hinge problem in the context of the pelvic floor?
So the hinges represent muscle coordination. This is a purely functional layer. It means the muscles are physically intact, but they aren't firing correctly.
Okay.
They might have poor activation, where they fail to contract when they're supposed to, or they might have reduced endurance, meaning they tire out quickly and just give up.
So they just get exhausted.
Right. And when the muscles fail to stay consistently engaged, the baseline resting tone of the pelvic floor drops. This leads to a reduced sensation of closure and occasionally light urinary incontinence.
The physical hardware is there, but the neurological communication telling the muscles to stay tight is kind of glitchy.
Exactly. The door isn't closing all the way because the hinges are loose and unresponsive.
But then you have the second layer, the weather stripping. The sources spent a significant amount of time on this, linking it directly to shifting estrogen levels.
Yeah, the surface layer is entirely about tissue health and cellular integrity. When the body enters a hypoestrogen state, which happens during menopause or sometimes temporarily during breastfeeding, the mucosal lining undergoes a really drastic physiological change.
Because estrogen is the hormone responsible for keeping that tissue plump.
Plump, elastic, and well lubricated. Without sufficient estrogen, the tissue rapidly thins out and loses its elasticity.
Now, the briefings mention a symptom here that initially seemed completely contradictory to me. They refer to it as the loose yet sore paradox.
Yes.
I really struggled to wrap my head around how a physical space can feel loose, but simultaneously hurt like it's too tight.
It really just comes down to the raw physics of friction on vulnerable tissue. Because that surface tissue is drastically thinner and lacks its natural lubrication, any movement or intercourse creates intense abrasive friction. And this friction literally causes microscopic tears in the mucosal lining. So the patient's brain registers the reduced elasticity and the thinning of the walls as a subjective feeling of reduced support.
Interpreting it as looseness.
Right. But simultaneously, those micro tears expose underlying nerve endings, causing burning, rawness, and soreness.
So the lack of weather stripping means the structural seal feels wet, but the exposed, irritated tissue makes any physical contact incredibly painful.
Exactly.
Okay, so we have weak hinges causing functional looseness and missing weather stripping causing a painful friction-based looseness. But our core mission today is about the third layer,
The wooden door frame.
the structure.
This is where physical anatomical damage comes into play. Structural looseness isn't about muscle timing or hormone levels. It is about physical tissue, connective fascia, and muscle attachments that have been mechanically altered
Stretched beyond their yielding point.
or literally torn apart.
Here's where it gets really interesting. If we're looking at a structural break in this door frame, what does that actually look like inside the human body?
Well, the medical texts describe the pelvic floor as a muscular trampoline.
A trampoline.
Yeah, it stretches from the tailbone in the back to the pubic bone in the front and side to side between the sitting bones. All the major pelvic organs essentially rest on top of this trampoline canvas.
So it's a highly dynamic trampoline.
Very much so. It needs to bounce and absorb intense downward pressure when you cough or laugh or jump. But it also relies on a central anchor point right in the middle called the perineal body.
Okay.
This is the central tendon of the perineum, sitting directly between the vagina and the rectum. It is the crucial junction where multiple muscle groups intersect and attach.
And what happens when that gets damaged?
When a permanent, unhealed tear happens in this dense connective tissue during childbirth, the clinical terminology used is a deficient perineum.
And there is a very specific metric given for this diagnosis, right? The clinical guidelines define a deficient perineum as one where that central anchor tissue has been reduced to measuring less than 2.5 centimeters.
Right. If the perineal body measures under 2.5 centimeters, it can no longer provide sufficient structural support for the organs resting above it.
I mean, I need to stop you there because 2.5 centimeters is tiny.
It's small.
It's roughly an inch. How can being short a half inch of tissue cause an entire muscular trampoline to fail?
It is entirely a matter of leverage and biomechanical tension. Think about a tightly pitched camping tent.
Okay.
If you move one of the main structural pegs inwards by just a single inch, what happens?
The entire side of the tent goes visibly slack.
Exactly. The perineal body acts exactly like that primary peg. It maintains the continuous tension required to keep the vaginal opening closed at rest.
Oh, I see.
When that peg is reduced by severe scarring or tearing, the vital tension is lost. That structural slackness leads directly to a clinical sign called introital gaping.
Meaning the vulva literally gapes open. Yes.
The door frame is structurally propped open because the tension holding it shut is just gone.
Because the anchor is compromised, the baseline resting tone of the opening physically cannot be maintained by the surrounding muscles. And this manifests in very distinct mechanical symptoms.
Like what?
A patient with this structural gap will frequently report air trapping.
I found this detail so striking
Yeah.
because it is rarely talked about openly, yet it perfectly illustrates a mechanical failure.
Right. Air physically enters the vagina during everyday movements like doing yoga or simply bending over and then makes a sound when it's forced back out.
Because that physical structural seal is broken.
There is no physical barrier to prevent air from entering the cavity when the internal pressure of the abdomen shifts. And another hallmark of a structural defect is tampon slippage.
Oh, right.
A patient might have phenomenal muscle coordination. They can clench those functional hinges perfectly on command, but if they go for a run, the tampon slides right out.
Wow. The functional muscles are firing, but they have nothing to squeeze against because the structural tissue that normally creates the friction and closure is simply gone.
That makes complete sense. If the door frame is physically wider than the door, it doesn't matter how strong the hinges are. The door will never seal.
Exactly.
And the physical trauma isn't always limited to just that central perineal anchor. The medical texts also detail something called a levator avulsion.
Yes. The levator ani is the main deep muscle complex of the pelvic floor. It forms the bulk of that muscular trampoline.
Okay.
An avulsion occurs when this muscle violently detaches from its insertion point on the inferior pubic ramus, which is part of the front pelvic bone.
Wait, hold on. So you mean the muscle is literally tearing right off the bone itself?
It physically rips away from the bone.
Oh my God.
And when that detachment happens, it dramatically alters the shape and width of what we call the genital hiatus, the central opening of the pelvic floor. Normally, it's shaped like a tight V. An avulsion forces it open into a wide, loose U shape. Going back to our trampoline analogy, an avulsion means the canvas has physically detached from the metal ring holding it.
Leaving a massive unsupported gap along the side.
Exactly.
So what does this all mean? If someone has this deficient perineum, this structural crack in their foundation where they are missing that tension, does it just stay a localized problem? Like, does the air trapping just stay air trapping?
No, it almost never stays localized over the long term. If we connect this to the bigger picture, we have to look at the integral theory to understand why.
Which was a foundational concept in the texts we reviewed.
Right. The integral theory posits that the pelvic floor is a highly interdependent suspension system. The bladder, the vagina, the uterus, and the rectum aren't just sitting statically in a bony bowl.
Right, they aren't just resting there.
No, they're actively suspended by a complex interconnected web of ligaments, fascia, and muscles.
So if the perineal body in the back is one of the main support cables and it snaps, how does that physically affect an organ in the front, like the bladder?
Think of a suspension bridge spanning a wide river. If the main anchoring cable on the south bank gives way, the bridge doesn't just break on the south side.
The sudden loss of tension causes the entire roadway to sag?
Exactly. The remaining cables on the north side are suddenly forced to take on twice the weight they were designed for. Eventually, under the constant downward pressure of gravity and traffic, those secondary cables stretch and fail.
Wow.
In the human pelvis, when the perineal support at the bottom fails, the constant daily pressure of living, walking, lifting groceries, even just coughing or breathing, forces the other organs to shift and fall into the newly created space.
This is the mechanical onset of pelvic organ prolapse.
Yes.
The internal organs actually bulge into the vaginal space because the physical floor beneath them has given way.
Depending on where the tension fails, different organs collapse. If the front wall of the vagina weakens because of this shifted tension, you develop an anterior prolapse, clinically known as a cystocele.
And that's when the bladder loses its bottom support and bulges backward and downward into the vaginal canal, which thoroughly explains the urinary symptoms we read about. The bladder is physically kinked out of its normal anatomical position.
The urethra, the tube that empties the bladder, gets bent out of alignment. It is exactly like putting a kink in a garden hose.
Okay.
The patient will feel an urgent, constant need to go, but because of the kink, they physically cannot fully empty the bladder, which leads to stagnant urine and frequent urinary tract infections.
That sounds miserable.
Some patients actually have to lean far forward or physically shift their position to straighten biological hose out just to be able to pee.
And the exact reverse mechanical failure can happen with the rectum.
That is a posterior prolapse or recticell. The lower wall of the vagina loses its foundational perineal support, and the rectum bulges upward and forward, protruding into the vaginal space.
The clinical texts get very visceral when describing how patients experience this daily. I mean, women aren't reporting a vague sense of discomfort.
No.
They describe a profound, heavy, dragging sensation, frequently saying it feels like they are permanently sitting on a small ball.
The mechanics of a recticell create immense practical difficulties. When a patient attempts to have a bowel movement, the stool gets trapped in that forward-facing bulge.
Right.
The structural wall between the rectum and vagina is so weak that the act of pushing only inflates the bulge further, rather than moving the stool out.
Yeah, the guidelines note a significant portion of these women are forced to employ a technique called splinting.
Yes.
They literally have to use their fingers to physically push the bulge back inside the vagina or press upward against their perineum from the outside just to create a straight enough pathway to empty their bowels.
It's devastating. Having to manually hold your internal organs in place just to go to the bathroom is a profound mechanical failure.
And the psychological distress of dealing with that reality on top of the physical pain must be overwhelming, especially regarding intimacy.
Definitely. The text extensively discussed dyspareunia pain during intercourse caused by this altered anatomy.
Because you're dealing with tethered scar tissue pulling in the wrong directions, shifting organs, blocking the canal, and a constant looming anxiety about incontinence.
Knowing the severity of this structural collapse, we have to examine how the medical system triages these patients. Because when a patient presents with these symptoms, the looseness, the air trapping, the leaking, the heavy dragging feeling, the initial advice given by medical community and popular media is incredibly uniform.
Wait, aren't we all just told to do our Kegels?
Yeah.
I mean, I thought you just read a pamphlet on pelvic floor exercises in the waiting room and you're cured.
Right.
Squeeze at the stoplight?
And that generalized one-size-fits-all approach
Yeah.
is precisely why so many patients suffer for years in silence.
It's so frustrating.
The clinical guidelines are unambiguous about this. Pelvic floor muscle training is a phenomenal, absolutely vital tool for functional issues. If your hinges are weak, muscle training is the gold standard. But you cannot kegel away a missing anatomical structure. If you are missing an inch of connective tissue, squeezing an adjacent muscle will not magically regrow that tissue.
Not to mention, the source material points out that trying to learn this complex muscular coordination from a folded pamphlet is incredibly ineffective.
The failure rate is staggering. The data shows that up to 50% of people attempting pelvic floor exercises from written instructions get the technique completely wrong.
50%.
Yeah, they often end up bearing down instead of lifting up, which actually pushes the organs further down and makes a prolapse significantly worse.
So if the hinges are the problem, a specialized physiotherapist is essential to teach you how to isolate and activate those muscles properly.
Absolutely.
But if the problem is the door frame, if a patient has a confirmed structural defect like a deficient perineum under 2.5 centimeters, or a severe levator avulsion causing the suspension bridge to collapse, what is the actual medical fix?
When the structural defect is the primary driver of the gaping, the air trapping, and the cascading prolapse, the medical literature indicates that surgery is the necessary intervention.
Okay.
Specifically, a highly targeted procedure called a perineoplasty or perineorrhaphy.
Now, I want to pause here because whenever surgery on this specific area of the body is mentioned, popular culture tends to immediately frame it as a cosmetic designer vagina procedure, just a quick nip and tuck for vanity.
I'm glad you brought that up because the clinical texts draw a very sharp, definitive line here.
Yeah.
Perineoplasty is not a cosmetic endeavor.
Right.
It is a reconstructive, functional restoration. The surgeon's explicit goal is to physically rebuild the perineal body.
They're fixing the mechanics.
Exactly. They meticulously clear away the painful, tethered scar tissue from the original childbirth trauma, and they suture the deeper fascial layers back together. They are literally rebuilding that central anchor point, so the pelvic suspension bridge has its critical tension restored.
They are reconstructing the door frame so the muscles finally have something solid to attach to and pull against.
Yes. While the physical opening will naturally be reduced, that tightening is simply a byproduct of restoring normal human anatomy to its pre-injury state, not an aesthetic choice.
That makes total sense.
It stops the air trapping by physically recreating the seal, and it provides the robust foundational support needed to prevent the bladder and rectum from collapsing further into the canal.
But the post-operative care detailed in the hospital guidelines highlights that this isn't just a fix-it-and-forget-it surgery. There's a grueling 4 to 6 week recovery period where patients must strictly avoid high-friction activities.
Very strict.
And the most critical insight is that pelvic floor physiotherapy is mandated after the surgery.
Because the synergy between structure and function is vital for long-term success. The surgeon repairs the broken door frame. But after weeks of post-operative recovery and years of compensating for a broken frame, those muscular hinges are going to be stiff, weak, and uncoordinated.
So you need both.
Right. The specialized physiotherapist steps in to train the muscles, how to operate within this newly restored structure, ensuring the patient doesn't strain incorrectly and break the repair.
You need the urogynecologist to rebuild the anatomy and the physiotherapist to optimize the mechanics.
Treating a massive structural tear with only muscle exercises is futile, just as treating weak functional muscles with a scalpel is completely inappropriate.
So returning to our mission for this deep dive, can an untreated childbirth injury, specifically a perineal defect, cause an ongoing feeling of looseness?
The data is unequivocal, yes.
An untreated tear that reduces the perineal body to under 2.5 centimeters alters the fundamental physics of the pelvis.
It creates a physical structural gap.
A gap that causes air trapping, tampon slippage, and eventually acts as the first falling domino in a mechanical cascade toward pelvic organ prolapse.
It is a profound mechanical failure of the body's suspension system, plain and simple.
Which brings me back to the broken arm we talked about at the beginning. We treat the human body like the engineering marvel it is. If a carpenter blows out their shoulder or a runner tears a ligament in their knee, we don't hand them a generic pamphlet, tell them a loose, painful joint is just a normal part of getting older, and send them home.
No, we absolutely don't.
We give them MRIs, targeted physical therapy, and precise structural surgical repairs. The pelvic floor is a highly mechanical structure of levers, pulleys, cables, and anchors, just like any other joint. So consider this. Why do we so often expect women to quietly live with a broken foundation?
It's a double standard.
Why aren't we demanding the exact same standard of biomechanical repair for the pelvic floor that we do for every other joint in the human body?
That is the crucial conversation the medical community and patients need to be having right now.
Definitely something for you to mull over the next time you hear someone joke about having to cross their legs when they sneeze. Thanks for joining us on this deep dive.